You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Steve Feldman, and welcome to Medscape in Discussion. Today, we're talking about psoriasis and the dramatic impact treatments have on our patients' lives, and we'll get to that shortly. First, let me introduce my guest. He pretty much single-handedly introduced concepts of quality of life in dermatology, and he invented extraordinarily widely used instruments to measure our patients' quality of life, measures that are used in countless clinical trials. Let me quote him. Every day in the dermatology clinic, there are people whose lives are being ruined by their skin disease. My main ambition has been to measure this impact to help dermatologists put the patient's perspective at the heart of clinical decisions. Let's talk to him about how skin disease affect patients and the implications for treatment. I'm honored to present to you Professor Andrew Finlay. Welcome, Andrew.
Well, thank you very much, Steve. It's very kind of you to invite me along.
Listen, I know you're retired, but I imagine you are keeping as busy or maybe busier than ever. I'm getting kind of old myself, and I'm wondering what might be ahead of me. Tell me, what's retirement like? What are you doing? What have you given up that you miss?
Okay, well, really, this is the very first time in my life that I've ever got my time management right. You know, my life-work balance at last is right. So I'm having a great time. It's really the best time ever. So I'm having some proper time with the family, having a proper time with all my hobbies. I'm learning jazz piano. I'm keeping the garden nice. I'm sorting out a new little home we've got in London as well as here in Cardiff. And we just today, we just got the first copies of a new book. I spent lockdown creating a new book, Dermatology Training, The Essentials, which is a British Association of Dermatologists book. Although you're right, I retired from clinical work about 12 years ago. I'm still doing still quite actively involved in research and doing a lot on developing family quality of life measures. So I'm having a great time, Steve. I'd thoroughly recommend it. And the sooner you retire, the better, I would say.
Yeah, I think your idea of retirement is that of an obsessive compulsive workaholic.
Exactly.
I think you're publishing as much as ever.
I am, yes. And you kindly commented on a short article that we had in the BJD last year about being addicted to publication or publishing. And I'm certainly an addict.
Well, let's talk about psoriasis. When I see psoriasis patients, I think about basing their treatment on the severity of the disease. How do you think about that? Do you think about different severity categorization schemes?
You know, once when I was very, very early in my career as a dermatologist, I was once asked to go and do a ward consult. Patient who was in the cardiology ward. He just had a myocardial infarction. But when they stripped him off, he had very, very widespread psoriasis, probably a PASI of 40 or 50 or something like that. Absolutely huge. You know, as a green, keen new dermatologist, I was very enthusiastic about the treatments we had. Frankly, they weren't that great at that time. But I persuaded this guy who wasn't particularly worried by his psoriasis to get onto systemic therapy. What happened was this chap whose psoriasis was very severe, but in fact, whose life was in total equilibrium with his psoriasis. He wasn't actually bothered by it at all. What I did was I upset the stability of his psoriasis with my intervention and created a nightmare for him. Previously, he was living perfectly well with his psoriasis. He wasn't bothered by it. And I waded in and messed things up for him. So that's just an example of an inappropriate approach to somebody with psoriasis. You've got to listen to the patient and what the patient wants. But equally, and this is a message that has come from widespread surveys, both in the States and across Europe, patients time and time again say their doctors aren't really taking their psoriasis seriously enough, and they would prefer to be on more impactful, more effective, much more effective therapy.
That one patient you saw and you upset his balance. Do you upset his balance by making his psoriasis better?
No, what happened was that his psoriasis, that instead of being stable, then started lurching between being more severe, being more inflamed, and then periods of improvement. But the whole thing became a major thing in his life, whereas previously he was living with it quite successfully.
So when we see patients, we got to make a decision about treatment. What's better, to just use our clinical judgment and our wisdom, or to use some kind of formal score?
Well, being an old-fashioned clinician, I think clinical wisdom and judgment have got to be right up there. But in order to be able to apply our wisdom and judgment, we have to have the information. And if the only information that you have is the appearance of the skin, the area that it's affecting, the sites that it's affecting, if you don't have the patient's perspective, you're not, in my view, fully informed as to take the best decisions for that patient. So I think that the understanding the patient's perspective is an additional bit of information. You absolutely central. You've got to examine and, if appropriate, measure the severity of somebody's clinical psoriasis in terms of their signs. But in addition, by understanding the patient's perspective, you get a much broader view of the real situation, and your clinical decision making is better informed. And often it's better informed, pushing you to be more quickly into systemic therapy, for example.
So we see a patient, we measured the objective disease severity. We might assess the body surface area. If we see it's more than 5%, we're probably thinking, okay, topicals aren't practical. So you'd record a body surface area. Maybe, if you're compulsive, you'd record the average severity of the lesions, a global assessment of that. What patient information do I need? Do I just ask patient, how much is this affecting you? Or should I use a formal measure like the Dermatology Life Quality Index that you created?
Well, I'm obviously have a biased perspective of the potential value of the DLQI, but as you suggested, asking a simple question, that is the most fundamental thing of all, and probably it's the simplest. And for those people who, they're just really not interested in using questionnaires, that I think is a very simple, fundamental clinical thing to ask as part of your history taking. How is your life being affected by your skin disease at the moment? And if you can do that, and it doesn't take long to do it, you will be surprised very quickly by the answers that you get. And you'll also, I would guess, be surprised at how much knowing the information you get from that single simple question will help you take better decisions for the patient. Of course, there are a whole host of reasons why using a more formal measure, such as the DLQI, though there's several others also possible to be used. There are several reasons why that may also be helpful. In particular, it can jog you or reassure you into using therapy which you might not otherwise have used. There can also actually be another side to it, which is just worth mentioning in passing. It can, if you've got a DLQI score, for example, this can justify your therapeutic decisions if the patient then runs into some problems following the clinical decisions that you've taken. For example, suppose somebody gets some severe side effects from some therapy that you've started the patient on. The fact that you've measured the DLQI, you've got evidence that the patient's life was severely affected, might be helpful. That's just by the way, but it's just another facet. Of course, having a score is all very well, but you need to know what the score means. And the reason that the DLQI and some other measures, the way that they have been converted from being sort of research only usage into being potentially of value in the clinic, is that there are validated score meanings or score bands, if you like, for the DLQI. So we know that if the DLQI score is greater than 10, this means that the patient's life currently is being very severely affected by their skin disease. And that's like an alarm bell going off. DLQI greater than 10, you can hear those alarm bells ringing to get you to think about what else should we be doing for this patient. So it can be helpful in some clinical situations to have that reassurance that, yeah, you are, you really do understand this person's situation in some depth.
When it comes to the Dermatology Life Quality Index, this DLQI, I see it used in a lot of studies. And I think its greatest strength is it has been used in a lot of studies so that, I can compare different drugs on how much DLQI improvement there's been. I could look and see, yeah, psoriasis is horrible, but hidradenitis is even worse. There are other things we've learned from the DLQI?
Well, we've had quite a lot of surprises from it, in that there are people, such as the person I just first mentioned on the cardiology ward, whose DLQI, there are some people whose DLQI score is remarkably low in an unpredictable way. We've learned that because we understand the meaning of scores, we've learned that some interventions which apparently improve patients' clinical situation and also apparently improve to a certain extent their quality of life, they don't, the level of improvement doesn't actually reach meaningful improvement. So the other aspect of measuring quality of life with a score is that not only do we have descriptor score bands, but we can also look at the minimal clinically important difference, and that, which in the DLQI, by the way, is about 4 points on average. So really, if your DLQI score just changes by 1 or 2 or 3, well, so what? I mean, it's a pretty rough and ready measure anyway. But if it changes by 4 points or more, that's an important change. So there are a whole raft of ways in which the DLQI may give you information which you otherwise might have missed. For example, I'm not suggesting that the DLQI should be used as a psychological screening tool. It really shouldn't be used for that purpose. However, if you've got somebody with a high DLQI score, it's a perfectly reasonable thing as a clinician to think, might there be some other psychological factors here at play that the patient needs further help with?
Especially if it's out of proportion to the amount of psoriasis that you see.
Exactly. It might be a personality thing, but the patient might be depressed. We all know how frequently depression in people with psoriasis is not recognized, and it's a mistake I'm sure I've made many, many times over my clinical career.
In psoriasis treatment, biologics, I think, have been revolutionary, and I've seen that they provide much greater DLQI improvements than topicals or even oral agents. I now see a push towards trying to get patients completely clear with these new drugs. And part of the evidence for doing so is that if you get people completely clear, they have statistically significantly lower DLQI scores than patients who only get to almost clear. What do you think about that?
Well, from a patient's perspective, you want to be completely clear. If I had psoriasis, I would want to be completely clear, though you might well tolerate a small amount. So from a patient's perspective, it seems totally logical. From a pharmaceutical company's perspective, it also seems totally logical, because by definition, taking that point of view is likely to result in more frequent prescription of various drugs. And there's, as you've just said, there's the scientific evidence that it is an appropriate thing to try to aim for complete clearance. I think the person to adjudicate on this is not really you, me, or the pharma companies, it's the patient. And I would suspect that from the patient's point of view, the less psoriasis you have, the better. So I think it's a reasonable and appropriate approach from the pharmaceutical industry.
And if that statistically significant difference in DLQI is less than 1 and the MCID is 4, what is that telling us?
Well, I'll have to rewind here on what I was saying about the MCID, because the MCID in itself is a very rough and ready concept, which has been criticized on many fronts.
The MCID being the minimal clinically important difference in the DLQI.
Yes, the minimal clinically important difference. In reality, almost certainly, the figure that represents the minimal clinically important difference is actually an elastic one. You have to have simple concepts to be able to work with them in the clinic, frankly, but probably down at the lower level of scores from 0, 1, 2, 3, 4, 5, the MCID is probably much smaller. And up at the top end, the MCID is probably much greater. So 4 is a sort of average, if you like. But I agree with you, it becomes meaningless down at the 0 and 1 level.
When I got into dermatology, was focused on looking at lesions, making diagnoses. How did you get interested in patients' quality of life, and how did it lead you to creating a measure to assess quality of life?
Well, when I was training, my boss was a person who was very influential in British dermatology and actually internationally in the late 20th century, Professor Ronnie Marks. And he was obsessed with measurement. And he was obsessed with measurement of the skin, directly of the skin. So we spent all of our time as juniors helping in research, trying to measure the thickness of the skin or the roughness of the skin or ultrasounding skin, all these measurement techniques, which now have become very widespread and become much more better validated. Anyway, I was influenced in that way. When I started, if you like, on my own as a consultant in my first dermatologist job in Glasgow, it became pretty clear to me as these patients came through the door of my clinic, it became very obvious to me that the real reason they were there was not because of the severity, if you like, of their skin from our dermatologist perspective, but the real reason they were there is that their lives were being messed up in some way by their skin disease. And about the same time, there was an editorial in the BMJ, the British Medical Journal, from a bunch of rheumatologists saying how measuring quality of life in rheumatology was rather important and perhaps other specialties ought to look at this. So I thought, I read this and I thought, yeah, let's look at it. So I went to Index Medicus, which in those days was not tapping into Google Scholar or PubMed. It was going to the library, these huge, great heavy tomes. If you dropped one, you did a major injury to your foot. And I looked up quality of life in dermatology and measurement methods for quality of life in dermatology. They didn't exist. There were none. So not dermatology specific ones. And so I thought, well, they don't exist. Let's try and make one. So we created the Psoriasis Disability Index and then the Acne Disability Index. And then I realized that with 2,000 or more different skin diseases, it wasn't really an achievable object to come up with 2,000 different questionnaires, though frankly, looking around the literature now, it's getting a bit that way. But I thought we needed a single questionnaire, which we could easily use and would be simple to use in the clinic. Then with Dr. Gul Karim Khan, a PhD student of mine, we created the DLQI. To great acclaim, I don't think the paper was rejected by the British Journal of Dermatology. And probably for very good reasons. I don't think the draft we sent into them was particularly great, but I was so upset by it being rejected that after doing a bit more work on it, we sent it to clinical and experimental dermatology, who kindly published it.
You were the right person in the right place at the right time. And you were so far ahead of the reviewers at the BJD, they didn't understand. And how could they? Nobody was paying attention to quality of life at the time.
Yeah, well, that's right. Well, I quite often get articles rejected even these days. And I always console myself with, well, it must be an idea before it's time. That's how I look at it.
Yeah. One step closer to publication.
Exactly.
Yeah. What is it about skin disease that really bothers people?
Well, you get a range of different answers from different people with skin disease. I think probably it's the impact on their close personal relationships. That's the biggest, but the impact on work, social events, and studying, doing normal things around the house or going out shopping or whatever, all of those things all add up. But I think probably the number one thing is their impact on their close personal relationships. It raises a criticism, and a very important criticism of all measures, such as the DLQI, that they are a fixed series of questions which are based on information from people with skin disease. I mean, the DLQI was entirely based on information from people with skin disease. But by definition, they're not specific to that individual person. And what you really want to know is what the issues are for that particular person, which is why your suggestion when we started talking about this of just using a simple question, what is it that, how is your life being affected by the skin disease? That's got a huge strength because you find out from that particular individual what they're most concerned about.
What do you think would be the best way to help general practitioners manage their patients with psoriasis?
Well, first of all, to take it seriously, because time and time again, and this is probably being very unfair to many excellent general practitioners, time and time again, the story comes back that my GP didn't really take it seriously, kept me going on all these topical creams and ointments which didn't really work. And I eventually gave up rather than being referred on for more specialist advice. There's another aspect to it, and that is when topical therapies are prescribed, a mistake that happens time and time again, that insufficient quantities are prescribed. That's a practical issue.
I think it's very easy for dermatologists to be discouraged by the care primary care providers are giving, because over and over again, we see where they didn't take it seriously, where they prescribed insufficient drug quantities, where the patient didn't get well. And it's very hard for us to recognize that every time the primary care doctor does give the right amount, does take it seriously, and the patient gets well, they don't send us those patients. And so we never see all the successes that they're having.
I was just about to go on to say exactly the same, Steve. We have this massive selection bias in whom we see. And so it's very easy to get the impression, what the heck do these general practitioners think they're doing? I mean, all of the patients I see have all had some problems with their GP. But yeah, exactly. That's because the vast amount of patients who are being treated well by the general practitioners don't cross your threshold.
All right. What's one thing you want to pass along to our listeners before we wrap up?
Well, I think in your clinical practice, focus on what really matters to the individual patient sitting in front of you, and inform your clinical decisions with that additional information.
Professor Finlay, I think you've left our audience with a great sense that when you're managing patients with psoriasis, you have to ask that particular patient how their life is affected by their skin disease in order to know how best to treat them. Thank you so much for that and for your time today.
Thank you very much, Steve. Thank you.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on psoriasis.